Welcome to Basic Heart Sounds. The objectives describe the four components to the cardiac exam, including observation, palpation, percussion, and auscultation. Utilize the stethoscope to maximize the ability to hear subtle sounds. Describe the cardiac anatomy and physiology as it relates to heart sounds, including the components of the first and second heart sound and the characteristics of the third and fourth heart sound. Differentiate between clicks, snaps, rubs, and gallops, and between systolic and diastolic heart murmurs, and describe how a murmur is graded. So with observation or inspection, the first thing you want to do is determine what is the contour of the chest. Is it barrel-shaped? More important is to watch the patient breathe. Is there supraclavicular or intercostal retraction, which could indicate a blocked airway? Is there paradoxical movement of the abdomen, which could indicate exacerbation of COPD, respiratory failure, or a paralyzed diaphragm? Is there any degree of asymmetry or asynchrony of chest expansion, muscle wasting, or hypertrophy? Does a patient grimace with discomfort during breathing, which could be an indication of pericarditis? Chest deformities such as pectus excavatum, a depressed sternum with a narrow anterior-posterior chest diameter and an abnormally straight thoracic spine, and pectus carinatum, also known as shield chest, indicates a prominent bird-like sternum. These deformities may be associated with hereditary disorders involving congenital cardiac defects, valvular disorders, cardiomyopathy, aortic root disease, atrioventricular cardiac defects, just to name a few. Inspection and palpation of cardiac impulses is best performed with the patient supine and with a modest elevation of the head and the chest, not over 45 degrees. You want to observe the chest by looking down and from the side. A slight, abrupt inward pulsation normally can be seen over the left ventricular apex, located at the fifth intercostal space and approximately at the left midclavicular line, or about 3 to 4 inches left of the left border of the sternum. This is easier to see on thin-chested patients and children, although in children, the apex beat occurs at the fourth intercostal space and medial to the nipple. A hyperdynamic left ventricular impulse associated with severe aortic or mitral regurgitation is frequently visible and can cause occasional shaking of the entire precordium. In patients with severe dilated congestive cardiomyopathy, a double impulse may be visible over the apical region. Cardiac pulsations that are visible lateral to the left midclavicular line usually suggest cardiac enlargement. Leftward cardiac displacement due to fibrosis in the left lung, right-sided tension pneumothorax, massive pleural effusion, and thoracic deformities may also cause visible pulsations beyond the midclavicular line. With palpation, you want to place the palm of your right hand across the patient's left chest. The heel of your hand should rest on the left sternal border with your fingers extended below the left nipple. The point of maximum impulse, or PMI, is about a penny-size impulse that is felt with the tip of your finger. It is located approximately at the fifth intercostal space, midclavicular line. The PMI can be difficult to palpate while the patient is supine, so have the patient turn to his or her left side, which can make the PMI more obvious. The PMI can be especially difficult to palpate in patients with large chests, such as obesity or COPD. If the ventricle is dilated, the PMI is displaced laterally. In cases of significant enlargement, the PMI will be located near the axilla. Occasionally, the PMI will not localize to any one area, which does not necessarily indicate ventricular enlargement or dysfunction. The vigor or strength of the impulse should also be noted. This could indicate a regurgitation of the mitral and/or the aortic valve, which causes large stroke volumes in the left ventricle. A heave is a palpable lifting sensation. If this sensation is under the sternum and anterior chest wall to the left of the sternum, it suggests severe right ventricular hypertrophy. A heave felt at the apex suggests left ventricular hypertrophy, and this is associated with displacement of the PMI to the left. A thrill is a vibration produced by turbulent blood flow that is usually secondary to valvular abnormalities. It feels like a buzzing sensation, or similar to the sensation when a garden hose is kinked, which partially obstructs the flow of water. Percussion, although palpation as well as imaging such as chest x-ray and echocardiogram have largely replaced percussion in cardiac exams, it can still be useful. This is especially true when the point of maximal impulse or the PMI cannot be felt. Under these circumstances, cardiac dullness can occupy a large area, especially if there is a large pericardial effusion making the impulse undetectable. Cardiac percussion is performed starting at the very left of the chest, beginning from the left axillary line and percussing along the third, fourth, and fifth, and even the sixth intercostal spaces towards the sternum. Moving in this direction, the sounds move from resonance, which are hollow sounds heard over normal lung tissue, indicating air, toward cardiac dullness or thud-like sounds, which indicates fluid or solid tissue. If you click on the link below, it will take you to a video that will demonstrate cardiac percussion. So now we're going to get into the fourth component, auscultation, which is probably the most important component when it comes to the cardiac exam. Before we get into actual auscultation of heart sounds, I wanted to just briefly mention the stethoscope, which comes in all shapes and sizes. The most important component of the stethoscope is the chest piece, which contains both the bell and the diaphragm. The bell picks up low-pitched sounds or low-frequency sounds such as S3, S4, and your diastolic murmurs. The bell should be placed lightly on the chest, but firmly enough to block out the room noise. The diaphragm will pick up your higher pitch sounds or the high frequency sounds such as S1, S2, and your systolic murmurs. So the example of the stethoscope in the left upper corner shows how the bell and the diaphragm are separate. You can actually visibly see the difference. Whereas the Littman cardiology in the left lower picture on the left lower slide is the bell and the diaphragm is built into the one chest piece, and you place to hear the bell or to hear the low pitch sounds with the bell, you place the chest piece lightly on the chest, and to hear the diaphragm, you apply light pressure. The advantage of that I like about the Littman cardiology is that it does have outstanding acoustic sensitivity to help you with detailed auscultation. You can really hear the heart sounds much better. It has a tunable diaphragm where you can hear high and low frequency sounds by slightly adjusting pressure on the chest piece. And it also has a dual lumen tubing where the two sound paths are in one tube that eliminates the rubbing noises of the traditional double tubes that are found on some stethoscopes. And the headset is easily adjustable. It's actually quite comfortable. This slide just shows you very simple anatomy of the heart, the right side and the left side of the heart. The left with the left atrium, the mitral valve between the left atrium, the left ventricle, and then the aortic valve. The right heart is the right atrium through the tricuspid valve to the right ventricle, and then on out through the pulmonic valve and into the lungs. The top view, this is a cross section of the heart with the pulmonic valve, the aortic valve with both the right coronary and the left coronary circulation, the mitral valve and the tricuspid valve and the mitral valve. And notice that the mitral valve is considered a bicuspid valve with two leaflets. The mitral and the tricuspid valve are known as the AV valves or the atrioventricular valves. The aortic and the pulmonic valves are known as the semilunar valves. To auscultate the heart sounds, you first want the patient to either be in a supine or a seated position. You want to start by finding the angle of Louis, the sternal angle, also known as the manubriosternal junction, which is located at the second rib, which is easily felt as a small protuberance along the sternum. You want to use the diaphragm of your stethoscope. The aortic area is to the right of the sternal border, the second intercostal space. The pulmonic area is to the left sternal border at the second intercostal space. The tricuspid area is also to the left sternal border, but it is at the fourth intercostal space. And the mitral area is located at the fifth intercostal space, but it's at the left midclavicular line. Now you will note there is an area noted as Erb's point. This lies between the pulmonic and the tricuspid area at the left sternal border, third intercostal space. Erb's point is where you can auscultate the heart sound the loudest. As far as if you want to listen to a patient's heart rate, place your stethoscope at the third intercostal space, left sternal border, and you will hear the heartbeat the loudest. It reflects the closure of the mitral and the tricuspid valves. There are three standard positions that the patient can be auscultated in. We mentioned the supine position, and then there is the left lateral recumbent decubitus position. If the patient has a large chest, you can position that patient on his left or her left side. And also you can hear certain heart sounds much better, some of the diastolic heart sounds better when they're in the left lateral recumbent. You can also have the patient in the sitting position, and having them sit up and lean forward, you can hear certain heart sounds, specifically aortic regurgitation, which we will talk about a little bit later. The basic principles to auscultating heart sounds is first have the patient lie supine. Unless they're orthopneic, then you can raise the head of the bed. You want to listen for the rate and the rhythm. Note if the rhythm is it regular or is it irregular, and then note the rate and what the heart rate is. Is it fast? Is it slow? Listen only to one sound at a time. You want to listen to S1 at each of the auscultatory locations, your aortic, pulmonic, tricuspid, and mitral areas, and then listen to the S2 at each of the auscultatory sites, your aortic, pulmonic, tricuspid, and mitral area. Listen for normal heart sounds and then for any abnormal heart sounds. General principles is that heart sounds are influenced by air, fluid, or tissue. Typically, sounds coming from the left side of the heart are louder than the right, and valves on the left side of the heart normally close just before those on the right. And that's due to the higher pressure within the left atrium and the left ventricle. So sounds always occur on the left side, just a split second before they occur on the right side. Flapping of the valve leaflets is not enough to generate a heart sound. When the heart valves close, it's the sudden change in pressure causing vibration of the blood, valves, and the ventricular walls. These sound waves travel to the surface of the skin and can be auscultated with a stethoscope. In order to understand heart sounds, it's important to review the pressure and the volume relationships within the cardiac cycle. This is Wigger's diagram. It's a standard diagram that's used in cardiac physiology, and it's a graphical representation of the cardiac cycle. Now you'll note that there are several components in this Wigger's diagram. It's a graphical representation of the cardiac events through diastole, systole, and back to diastole, and illustrates the cardiac cycle as it relates to the left atrium and the left ventricle. The top portion of the graph represents time and the EKG, and sometimes you may see this at the bottom of the graph. Now, in the middle of the graph, there are three lines that deal with pressures. There's the aortic pressure, reflected in the black line. There's the left ventricular pressure, which is reflected in the red line. And then there is the left atrial pressure, which is reflected in the blue line. At the very bottom is the left ventricular volume. The left ventricular volume is the blood contained within the left ventricular chamber at any given point in the cardiac cycle. The difference between the maximum and the minimum value is the volume of blood that's ejected by the left ventricle. So you'll notice With the left ventricular volume, the stroke volume at number 3 at the end of diastole is 130 milliliters. At the end of systole, the amount of blood in the ventricle is 50 milliliters. So the ejection fraction is determined by 130 milliliters minus 50 milliliters equals 80 milliliters. 80 divided by 130 is 61.5. So the ejection fraction in this case is 61.5%. This is a quick overview of what is happening during the cardiac cycle, and then we will break it down even further. You'll notice that on number 1, the circles number 1 on the graph will correspond with the numbers on the left-hand side of the slide. First, there is rising atrial pressure that pushes blood into the ventricle, and this is reflected on the blue left atrial line that is on the graph. Number 2, atrial systole occurs. Number 3, the end diastolic volume of the blood is in the ventricles. And note the red left ventricular line under the left ventricular volume, that the stroke volume is at its highest, 130 milliliters at the end of diastole. Number 4, the isovolumetric contraction of the ventricles. The ventricles are contracting, but there is no blood flow. Number 5 is the ventricular pressure increases, forcing blood through those semilunar valves, your aortic and pulmonic valves. Number 6, the period of isovolumetric relaxation when all heart valves are closed. Number 7 is atrial pressure forces the AV, the atrioventricular valves open. These are your mitral and tricuspid valves. And then number 8, the cycle will begin again. There are 6 phases to the cardiac cycle, and phase 1 is the ventricular filling, also known as mid-diastole. The atrial and ventricular diastole is occurring at this time. There is rising atrial pressure that pushes blood into the ventricle. The ventricular volume begins to increase. Atrial depolarization begins. Note the P wave is on the EKG. Also note that the AV valves are open and the semilunar valves are closed during this phase. Phase 2 is atrial contraction or late diastole. The atrial systole and ventricular diastole are occurring during this phase. The atrial contraction pushes the remaining blood into the ventricles. Ventricular pressure begins to exceed atrial pressure as the full ventricle begins to contract. Atrial depolarization is complete and the ECG reflects, the P wave is reflected on the EKG. Also note the AV valves are open, the semilunar valves are still closed at this time. Phase 3 is the isovolumetric contraction. This is when the atrial are in diastole and the ventricles, it's early ventricular systole. Ventricular pressure exceeds atrial pressure as the full ventricle begins to contract. There is no volume exchange and it is considered isovolumetric. The AV valves close. This is where we will hear S1, and the mitral valve will close prior to the tricuspid valve. We call it M1T1. The ventricular depolarization begins. The QRS is noted on the EKG. Isovolumetric contraction is an event that occurs in early systole during which the ventricles contract with no corresponding volume change. During this time, the ventricular chamber is actually geometrically changing its shape and becoming more spheroid. The circumference increases and the atrial base to apex length actually decreases. And the heart is beginning to contract, and when it contracts, it's starting to twist or rotate in a clockwise fashion. During the time period between the closure of the AV valves and the opening of the aortic and pulmonic valves, ventricular pressure will rise rapidly because of this change in its geometry without any change in ventricular volume, so no ejection has occurred yet. Ventricular volume does not change because all of the valves are closed during this phase, and therefore contraction is said to be isovolumetric. So there's no change, there's no exchange of volume at this time. And the QRS, it represents the ventricular depolarization, basically the onset of this phase. Phase 4 is the ventricular ejection phase. This represents atrial diastole and ventricular systole. Ventricular pressure exceeds pressure in the semilunar valves, pushing the valves open with rapid ejection of blood into the aorta and the pulmonary arteries. Normally, no sound is heard, but if the valves are stiff, such as in aortic stenosis or pulmonic stenosis, an ejection click may be heard as those valves open. The ventricles are depolarized. This is reflected by the ST segment on the EKG with repolarization, which is reflected by the T wave on the EKG. The AV valves are closed and the semilunar valves are open. Phase 5 is the isovolumetric relaxation. This is when both atrial and ventricles are in diastole. The intraventricular pressure falls. The pressure within the aorta and the pulmonary arteries exceeds pressure in the ventricles. The semilunar valves close. This is reflected as S2. The aortic valve closes just before the pulmonic valve, again because of the pressures higher on that left ventricle. There is, with the valve closure, that there is an associated small backflow of blood into the ventricles, so a dicrotic notch can be formed on the aortic and pulmonic tracings. The ventricles are electrically silent at this time. It's reflected as the TP interval on the EKG. At this time, all of the valves, AV valves, and the semilunar valves are closed. Now, although ventricular pressures decrease during this phase, note the volumes do not change because all the valves are closed. The volume of blood that remains in a ventricle is called the end systolic volume, and it is about 50 milliliters in the left ventricle. The difference between the end diastolic volume and the end systolic volume is approximately 80 milliliters, and this represents the stroke volume. Phase 6 is rapid ventricular filling. At this time, both the atrial and the ventricles are in diastole. As the ventricles relax, the pressure in the atria exceeds the pressure in the ventricles, pushing the AV valves open, your mitral and tricuspid valve. Again, normally no sound is heard, but if the valves are stiff, an opening snap may be heard. The ventricles continue to remain electrically silent and is reflected as the TP interval on the EKG. The AV valves are open and the semilunar valves are closed during this phase. As the ventricles continue to fill with blood and expand, they become less compliant and the intraventricular pressure rises. In normal resting hearts, the ventricle is about 90% filled by the end of this phase, so about 90% of ventricular filling occurs before atrial contraction, which is phase 1, and therefore it is passive filling. The aortic and pulmonary arterial pressures will also continue to fall during this period. Early in ventricular diastole, the blood flows by gravity from the left atrium into the left ventricle. If the ventricle is forced to dilate beyond its normal range because the atrium has an overloaded volume, an S3 will occur. Ventricular filling is normally silent. A third heart sound may be normal in children, pregnant women, and well-trained athletes, but it is often pathological in adults and is caused by ventricular dilation or heart failure. If the left ventricle is not overly compliant, as is in most adults, an S3 will not be loud enough to be auscultated. A clinical pearl is an S3 heart sound is often a sign of systolic heart failure. However, it may sometimes be a normal finding. And remember, at the end of ventricular diastole, the left atrium contracts, increasing the pressure in the left atrium. If the left ventricle is non-compliant and atrial contraction forces blood through the atrioventricular valves, a S4 is produced by the blood striking the left ventricle. Any condition that creates a non-compliant left ventricle will produce an S4, whereas any condition that creates an overly compliant left ventricle will produce an S3 heart sound. An S4 heart sound can be an important sign of diastolic heart failure or active ischemia and is rarely a normal finding, unlike an S3. Diastolic heart failure frequently results from severe left ventricular hypertrophy, resulting in impaired relaxation or compliance of the left ventricle. If an individual is actively having myocardial ischemia, the myocardium is not able to relax and an S4 will be present. If a patient is in atrial fibrillation, the atria are not contracting and it is impossible to have an S4 heart sound. We will begin with normal heart sounds, S1 and S2. In the diagram on the slide, it notes that S1 is the onset of systole. S1 also reflects closure of the mitral and the tricuspid valves, M1, T1. S2 is the onset of diastole, or the closure of the aortic and pulmonic valves, A2, P2. Click on the YouTube video and you will see the valve closure during systole and diastole. And if you can, try to stop the video during those phases of systole and diastole and note the valvular closures. S1 and S2 are near discrete sounds created by near instantaneous closure of two separate valves. These sounds are single and instantaneous, at least they sound that way, but they're not. S1 is closure of the mitral valve, slightly precedes closure of the tricuspid valve. In S2, closure of the aortic valve slightly precedes closure of the pulmonic valve. In ventricular systole, the aortic and pulmonic valves are open and the mitral and tricuspid valves are closed. The pressure in the left ventricle is much greater and therefore the left ventricular events happen slightly before events in the right ventricle. Therefore, the mitral valve closes a split second before the tricuspid valve closes. During diastolic filling of the ventricles, the mitral and the tricuspid valves are open and the pulmonic and aortic valves are closed. So at the start of diastole, pressure in the aorta is much higher than in the pulmonary artery. Therefore, the aortic valve closes a split second before the pulmonic valve. The cadence of the beat will distinguish between S1 and S2. S1 is the onset of systole. S2 is the onset of diastole. There is a longer pause between S2 and S1 because diastole is twice as long as systole. Note that the QRS occurs just before S1, the onset of systole. That is because the electrical activity is detected more quickly than the sound. So let's look at the first heart sound, S1. It's due to the mitral and the tricuspid valve closure. It signifies the onset of systole. It is a low pitch and relatively long sound, and it is heard loudest at the apex. It can also be loud in hyperdynamic states such as fever, thyrotoxicosis, exercise, and pheochromocytosis. The second heart sound, S2, is due to the aortic and pulmonic valve closures. It signifies the onset of diastole. S2 can be somewhat higher pitched than S1, and it is heard loudest in the aortic and pulmonic areas. Rapid heart rates shortens diastole to the point where it is difficult to discern S1 from S2. Unfortunately, I could not get the link to work, but if you click on the easy auscultation link here on this slide, it will take you to the rapid heart rate example, and you can hear that and note the diastole and systole are almost the same. S1 will correspond to the carotid or radial pulse. So the heart sound heard when palpating the pulse is S1. When the pulse disappears, it is S2, and that is how you can discern between S1 and S2 on a rapid heart rate. It is a good habit to develop. Palpate the pulse when auscultating. When you have your stethoscope on that chest, palpate the radial pulse, and you'll note S1, and then S2, you will not feel it. So we'll talk about some of the abnormalities of S1 and S2, and that is splitting. Splitting of S1. Remember that the mitral and the tricuspid valve close pretty much together, the mitral valve just slightly before the tricuspid valve, so you never hear two sounds with the associated with the closure of those valves. But when there is a split S1, the tricuspid valve, you will hear the closure or a sound associated with the closure of the tricuspid valve, so they call it splitting. In some patients, a mild splitting may be heard. A fixed splitting is often associated with a right bundle branch block pattern or Ebstein's anomaly, which is a congenital heart defect in which the opening of the tricuspid valve is displaced towards the apex of the right ventricle of the heart. You want to listen in the tricuspid area, fourth intercostal space to the left of the sternum. Have the patient in the supine position and use the diaphragm of your stethoscope. Unfortunately, I cannot get this link to work, so I'm going to ask you to follow the links on this slide, and you will be able to hear a minimally split and a markedly split S1. So we talked about a physiologic split S2. Now we're going to talk about a fixed split S2, and this remains unchanged throughout respiration. Inspiration, expiration, you're going to hear the fixed split S2. It does indicate disease. It could be an aortic septal atrial septal defect, could be from cor pulmonale, or it could be from a bundle branch block. There can be wide splitting, where there's increase from a normal split S2, which lasts throughout the cardiac cycle. There can be a fixed split, which is what we're talking about here. It does not vary with respiration. There can also be a paradoxical or a reverse split, where the split S2 disappears with inspiration, but it appears with expiration. So there's different types of splitting. Again, it can occur with pulmonary stenosis, a right bundle branch block, atrial septal defect, right ventricular failure, or even a left bundle branch block. Again, it's a fixed split S2. It will stay throughout inspiration, expiration. You will hear it in the pulmonic area. The patient is supine, and use the diaphragm of your stethoscope. Unfortunately, the heart rate was a little faster, so it was difficult to hear. But if you go back and listen to the physiologic split, instead of ending, it will be continuous. So now we will move to clicks, snaps, and rubs. An ejection click occurs early in systole. Remember when we were talking about Wigger's diagram, and I had mentioned when the aortic valve, if it is stiff, when it opens, an ejection click may be heard following S1. It can mimic a split S1, but again, location. A split S1 is heard at the tricuspid area. The ejection click is shorter in duration, and it is a higher pitch than S1. So for an ejection click, you will hear this in the aortic area. Ideally, the patient will be sitting. That's the best way to hear this. And you want to use the diaphragm of your stethoscope. So it's a single first heart sound, S1, followed by an aortic ejection click, can also mimic that split first heart sound. An aortic ejection click is caused by thickened aortic valve leaflets, and it's commonly seen in bicuspid aortic valves, which is a congenital abnormality where someone is born with 2 aortic valve leaflets instead of the normal 3. You want to listen carefully to the second sound of the pair. If it's an ejection click, it will have a shorter duration and a higher pitch than the first sound of the pair, or S1. Again, it's heard best at the aortic valve area where the splitting of S1 is not heard. Split S1 is heard best at the tricuspid area. Ejection clicks are heard at the same time as a murmur in many cases and can have the same etiology. So if you hear an ejection click, the chances are they also have an aortic stenosis because it's a tight, calcified valve. An opening snap is caused by thickened valve leaflets. When they open, it produces a snapping sound. The more severe the thickening, the earlier in diastole the opening snap occurs, and these sounds are associated with mitral stenosis. It can mimic a split S2, which is heard at the pulmonic area, but an opening snap is heard in the mitral area, so it's the 5th intercostal space, midclavicular line. The patient should be supine, and you use the diaphragm of the stethoscope. Again, it is a diastolic heart sound and is associated with mitral stenosis. A pericardial friction rub is when the heart is beating against an inflamed pericardium. It's a continuous sound throughout systole and diastole. It is louder on inspiration, and it's accentuated with a patient leaning forward. The best place to hear a pericardial friction rub is at the 3rd intercostal space left sternal border, also known as Erb's point. And have the patient sit up and lean forward using the diaphragm of your stethoscope. The best way to describe a pericardial friction rub is take 2 pieces of sandpaper and rub them together, and that also will simulate a pericardial friction rub. These patients tend to have, if it's severe, they will have a lot of pain, and sometimes you'll find them leaning forward because they're trying to relieve the pain. So we have talked about S1 and S2. We've talked about ejection clicks and opening snaps. The gallops will include S3 and S4 heart sounds. Remember, S1 is closure of the mitral and tricuspid valves, which is the onset of systole. If the aortic valve is stenotic and stiff and opens, you may hear an ejection click. S2 is the onset of diastole and represents the closure of the aortic and pulmonic valve. When the mitral valve opens during diastole, an opening snap may occur if there is a stiffened mitral valve or mitral stenosis. We'll begin with the S3 heart sound. It occurs in diastole. It is a faint, low-pitched sound heard every third or fourth beat. It's normal in children and young adults. The exact mechanism is controversial but related to the timing of ventricular filling pressure. It's generated when the ventricle is forced to dilate beyond its normal range because the atrium has an overloaded volume, which can occur in mitral regurgitation. You want to listen at the apex. Place the patient in the left lateral recumbent position using the bell of the stethoscope. The cadence sounds like Kentucky, Kentucky, Kentucky. So here you have the EKG along with the heart sound, S1, S2, and you'll note that S3 occurs just after S2 and does occur in the diastolic phase. I have to apologize. I don't know why the S3 started. Actually, a gallop is what that sounded at the end. But at the beginning of each of those examples, you could hear the S3. And again, I have the links. Go to the Easy Auscultation site at those links, and you can actually hear the S3 heart sounds. Now we're going to talk about, is it S4, split S1, or ejection sound? S4 is eliminated with pressure on the stethoscope. Remember, S4 is a low-pitched sound. The S3 and S4, they're low-pitched sounds. You want to use the bell of the stethoscope. So if you put pressure on the stethoscope, it will eliminate. Pressure does not eliminate ejection sounds or a split S1. Those are higher-pitched sounds. So ejection sounds and split S1s you can hear with the diaphragm. S4 is usually not heard over the aortic area. An aortic ejection sound is heard over the aortic area. S4 is frequently found in patients with coronary artery disease, and it is a common finding in hypertension. So anyone who has hypertension and an S4, that heart is affected. There's probably left ventricular hypertrophy. An S4 heart sound occurs late in diastole. It's associated with the atrial kick, where the final 20% of the atrial output is delivered to the ventricles. It's due to forceful atrial contraction into the ventricles with limited distensibility, such as left ventricular hypertrophy, hypertension, aortic stenosis, or pulmonary hypertension. So patients with atrial fibrillation do not have an S4. If you listen in the tricuspid area, fourth intercostal space to the left of the sternal border, and you're using the diaphragm, you are hearing a split S1. With the S4, you listen at the apex with the bell of the stethoscope. Place the patient in the left lateral recumbent position. The cadence is like a stiff wall, a stiff wall, a stiff wall, and it's most likely heard with every beat. So here again, you have the EKG, and you notice you have S1, S2, and the S4 does occur in diastole, but late in diastole, just before S1. A quadruple gallop is produced by all four heart sounds, S4, S1, S2, and S3. It literally sounds like a galloping horse. It suggests congestive heart failure, and the cadence is, I can't keep up. The summation gallop is a heart rate of 120 beats per minute or more. The diastolic period shortens, and the S3 and S4 are superimposed, creating a single sound. And once again, I am unfortunately cannot open these links, so I can ask you if you would go to these links and you can hear the quadruple gallop and the summation gallop. So now we'll move on to the murmurs. Cardiac murmurs can be divided into three categories based on where they occur in the cardiac cycle. They can be systolic, diastolic, or continuous. There are characteristic properties of murmurs. First, you want to find the location. Where is it heard best, and does it radiate? If it radiates, where does it radiate? What is the timing? Is it systole or diastole? And you want to time it against S1 and S2. Remember, S1 is closure of the mitral and the tricuspid valves, which is the onset of systole. So your pulse will correlate. Again, what you're feeling is when you're feeling the radial pulse, that is the onset of systole. You want to look at the quality and the shape. Quality refers to the type of noise that's produced. It can be a combination of frequencies. Words that have been used to describe it are booming, rumbling, blowing, harsh, or musical. Does the murmur completely fill the cycle? Does it have discrete start and end points? And then you want to look at the grade or the intensity, which refers to the loudness of the heart sound. It's related to the pressures that are generated and the blood flow velocity. It can be related to a patient's size, their body build, and chest configuration. Slender patients have a thinner chest wall, which allows for sounds to be transmitted more easily than would be through an obese patient's chest wall. Murmurs can take on all shapes and sizes. They can be early diastolic murmurs, mid-diastolic murmurs, early systolic, mid-systolic, late systolic murmurs, and there can also be holosystolic murmurs, or also known as pansystolic murmurs. I'm going to, hopefully this will work, and you can hear a holosystolic murmur. The crescendo murmur begins in mid-systole and ends before diastole. Here's the crescendo murmur. A decrescendo murmur, this is an example of a diastolic murmur. And then the crescendo, decrescendo are also known as a diamond-shaped murmur. This is a systolic murmur. Murmurs are graded using a scale from grade 1 through grade 6. Grade 1 it's considered grade 1 over 6 if it is very faint, only heard in ideal circumstances, and a palpable thrill is not present. Very common to hear a grade 2 over 6, and this is usually audible by all listeners. Again, there is no thrill present. A grade 3 over 6 is easy to hear even by inexperienced listeners. Grade 4 over 6 is the same as a 3, but you will feel a thrill. You can palpate a thrill on the chest. Grade 5 over 6 is audible with the stethoscope partially off the chest, and then a grade 6 over 6 is heard with the stethoscope off of the chest. It is important to decide if a murmur is clinically significant or not. Just as a murmur can be caused by normal flow through a stenotic valve, it may also be created by high flow through a normal valve. Pregnancy is a common high volume state where these physiologic flow murmurs are often heard. Anemia and thyrotoxicosis can cause high flow situations where the murmur is not pathologic itself, but it indicates an underlying disease process. Children also frequently have innocent murmurs, which are not due to underlying structural abnormalities. So how does one determine if a murmur is significant or not? It's through the history and physical exam. It's important to evaluate any other symptoms that may correlate with the murmur that you're auscultating. If you do hear a murmur, it is prudent and part of the guidelines to obtain an echocardiogram. We're going to first look at the systolic murmurs. And at the bottom of the slides on the mitral regurgitation and the aortic stenosis slides, you will notice YouTube videos. And I encourage you to click on those, and those will bring up an example of what the mitral regurgitation looks like. And if you can stop the video, you'll note that during systole, the mitral valve is open, causing the regurgitant flow. In aortic stenosis, you will note that if you can stop the video during systole, the aortic valve is not open as wide. It's a stenotic valve, so the opening is actually quite narrow. So if you're able to do that, please click on those YouTube videos. Mitral regurgitation is a common systolic murmur. It is due to leakage across the mitral valve into the left atrium during ventricular contraction. The murmur is caused by turbulent flow through an incompetent mitral valve leaflets. The murmur is usually best heard at the apex with radiation into the axilla. Because the mitral valve is unable to contain the blood within the ventricle for the entire systolic period, it is a holosystolic murmur. The quality of the murmur is usually described as blowing, and it is often associated with an S3 because of the left atrial volume overload. You want to have the patient in the supine position and use the diaphragm of your stethoscope. Severe mitral regurgitation or turbulent blood flow from the left atrium to the left ventricle during diastole can occur due to too much blood in the left atrium, which forces blood back into the left ventricle, creating a flow rumble. A maneuver which may increase the intensity of mitral regurgitation is transient arterial occlusion. Essentially, when the blood pressure cuffs are used to completely occlude the brachial artery for a short period, the resultant increase in arterial resistance causes the left ventricle to increasingly favor the regurgitant mitral valve as an outlet for flow. This flow will increase and enhance the intensity of the murmur. Aortic stenosis is also a systolic murmur, and in the U.S., it's most commonly due to degenerative disease, calcification due to age, or a bicuspid valve, a two-leaflet valve, causing obstruction to blood flow from the left ventricle into the aorta. It is a diamond-shaped crescendo-decrescendo murmur. Aortic stenosis is a progressive disease, and the phase during systole at which the murmur peaks can help determine the severity of the murmur. When you listen to the aortic valve area, you want to listen to in the aortic valve area. You will note radiation to the carotids. Have the patient in the supine or the sitting condition and use the diaphragm of the stethoscope. In aortic stenosis, there can be what is called aortic sclerosis, which is characterized by regular vibrations, which give the murmur a musical quality or a cooing sound. Early aortic stenosis is an early peaking, harsh, diamond-shaped murmur and is considered mild aortic stenosis because of the early peaking. Notice that the murmur is in early systole with a harsh quality and a crescendo-decrescendo shape. Because it is an early peaking, it would suggest an earlier stage of aortic stenosis rather than a late peaking murmur, and it can be accompanied by an ejection click. Late aortic stenosis occurs later in systole, is harsh, diamond-shaped murmur, similar to early aortic stenosis, but it is later occurring in systole, and that's the sign that it is a severe aortic stenosis. The problem is that with late or severe aortic stenosis, the valve is so poorly mobile and severely diseased. And in some cases, depending on how severe, these patients are usually set up for a surgical procedure to replace the aortic valve, or the newer procedure that is out is the TAVR, the trans-aortic valve replacement. Tricuspid regurgitation is due to leakage back into the right atrium across the tricuspid valve during right ventricular contraction. There is some degree of tricuspid regurgitation in over 80% of the population. Inspiration may accentuate the sound. Again, you want to listen over the tricuspid area. That's the fourth intercostal space left of the sternal border. The patient should be supine. Use the diaphragm of the stethoscope. You may hear a very common holosystolic murmur, and the intensity can increase with inspiration or if you apply pressure over the liver. Pulmonary stenosis is an infrequent cause of significant murmurs and is often a part of congenital disorders. The murmur of pulmonary stenosis is heard best in the pulmonic area, the second intercostal space along the left sternal border. The murmur can be heard radiating into the neck or the back. It has a crescendo-decrescendo shape and a harsh quality. Because it takes longer for the right ventricle to eject its load of blood through the stenotic valve, the closure of the pulmonary valve is delayed. This widens the slight gap between the closure of the aortic and pulmonic valves in S2 to a noticeable degree, and a significant splitting of S2 can be heard. Finally, maneuvers which increase venous filling and blood flow into the right ventricle, such as deep inspiration, will tend to increase the intensity of the murmur. And finally, last but not least, are the diastolic murmurs. Again, I encourage you to click on the YouTube videos that are listed on the mitral stenosis and the aortic regurgitation slides. And as you view those, try to stop the video during the diastolic murmur phase, and you will note that in the mitral stenosis, which should be wide open, it is not. It's quite stenotic. And the same with the aortic regurgitation. Instead of being fully closed during diastole, it is open. So you get regurgitant flow back into the left ventricle. Mitral stenosis is due to obstruction of blood flow from the left atrium into the left ventricle, primarily due to rheumatic heart disease. The mitral stenosis is much more common in females than males. It's usually a female-male ratio of 2 to 1. Congenital causes can also occur with mitral stenosis. It's heralded by an opening snap, which occurs earlier as the mitral stenosis becomes more severe. The duration of the murmur increases with severity. You want to listen in the mitral area. It's localized to the mitral area. Position the patient in the left lateral recumbent position. It is a low-pitch murmur, so it's important to use the bell of the stethoscope, and you can hear a crescendo, decrescendo, crescendo rumbling. Mitral stenosis can be mild, moderate, or severe. Here's an example of mild. An example of moderate. And an example of severe. Unfortunately, that sounds just like moderate, but the severe mitral stenosis compared to mild is when the opening snap or the mitral stenosis is occurring earlier in the diastolic phase. Aortic regurgitation is also common. It is due to leakage across the aortic valve back into the left ventricle during diastole. The left ventricle is dilated secondary to extreme volume overload due to both forward flow delivered from the left atrium as well as a regurgitant flow that's coming back from the aorta. It's a complex murmur depending on the severity. Mid-systolic murmur due to a large volume of blood ejected rapidly during systole. Not uncommon to hear the aortic area with radiation to the neck, and also not uncommon to hear a diastolic rumble known as an Austin Flint murmur due to the retrograde flow from the aorta to the left ventricle. The most common place to hear aortic regurgitation is anywhere along the left sternal border, especially at Erb's point. Have the patient sit and lean forward, hold their breath after expiration. So have them blow their air out and then hold their breath. You want to use the diaphragm and use firm pressure over that left sternal border. You may hear a blowing decrescendo murmur. And in severe aortic insufficiency or aortic regurgitation, it can be a holistic diastolic murmur that radiates all along the left sternal border. Tricuspid stenosis is rare, occurring in less than 1% of the population. It's due to obstruction of blood flow from the right atrium into the right ventricle, primarily due to rheumatic heart disease. It's associated with aortic and mitral valve involvement. You want to listen in the tricuspid area, fourth intercostal space to the left sternal border. You have the patient in the supine position using the bell of the stethoscope. It's usually a diamond-shaped murmur. You may hear a tricuspid opening snap, and there may be a second diastolic murmur due to left atrial contraction. It usually increases with inspiration. Pulmonary regurgitation is due to retrograde flow from the pulmonary artery back into the right ventricle during diastole. Mild to trace is present in almost all individuals on echocardiogram, but not on the physical exam. It's often not the primary process, but secondary to an underlying disease process such as pulmonary hypertension or dilated cardiomyopathy. You want to listen in the pulmonary area, second intercostal space to the left of the sternal border. Have the patient sitting up and leaning forward. Use the diaphragm of the stethoscope. An early diastolic decrescendo murmur that increases with inspiration and a fixed split S2 may be present. So again, please use the YouTube videos that are posted on the slides in order to visually see the stenotic and the regurgitant valves. Also, the easy auscultation is posted here along with other references, and by accessing these sites, you can hear more murmurs and heart sounds, including the S1, split S1, split S2, S3, S4, and the Gallup's murmurs, snaps, and clicks. Thank you.